Welcome to Chapter 9, Airway Management, Emergency Care, 14th edition. So let's talk about airway physiology. So the airway is divided into upper and lower portions. Your upper airway begins at the mouth and nose. It goes into the pharynx, and it lies posterior and inferior to the mouth and nose. The oropharynx is the upper portion, the nasopharynx is the middle portion, and the laryngopharynx is the lower portion. The larynx is the boundary between that upper and lower airway. The lower airway, it includes the trachea that lies below the larynx. The main stem bronchi branch from the trachea and progressively become smaller. And then the alveoli lie at the end of the bronchi. The pulmonary capillaries surround the alveoli, and oxygen and carbon dioxide are exchanged at those capillaries. So you've got your main stem, your trachea right here. Surrounding your trachea, you've got all of your your cartilage rings. These rings provide structure to the structure itself. And then down here you've got your bronchi, your bronchioles that come here, and then your alveoli, which will like grape-like structures here. These are your alveoli. These are just tiny air sacs that are empty, but they promote that's where the gas, the O2 and CO2 get exchanged. The pediatric airway, it is shorter and narrower and less rigid. The mouth and the nose are smaller and more easily obstructed. The tongue is proportionally larger. Newborns and infants are nose breathers. The trachea is softer, more flexible, and narrower, and more easily obstructed by swelling and foreign objects. The chest wall is softer, and breathing is more dependent on the diaphragm. So a variety of obstructions interfere with airflow. Foreign bodies, including food, small toys, liquids, including blood and vomit, loss of muscle tone, as with altered mental status. Obstructions can be acute or chronic, and the airway must initially be evaluated and monitored for patency over time. Severe allergic reactions or anaphylaxis could cause rapid airway tissue swelling. Burns, blunt force trauma, and certain infections cause swelling of the tissues in and around the glottic opening, and smooth muscle constriction of the lower airway passages change the diameter and create resistance as well. So 4 sounds can be indicative of limited air movement. They are stridor, hoarseness, snoring, and gurgling. Stridor is that high-pitched whistling sound. It is indicative of a severely narrowed air passage. Hoarseness is a raspy change in voice, indicative of swelling around the vocal cords. Snoring, similar to a snore during sleep, it is indicative of diminished muscle tone. Gurgling is a bubbling sound. It's indicative of vomit, blood, or secretions in the airway. So when we do our patient assessment, we want to know if the patient is, or the airway is open. We have to ask 2 questions. So is it open, and will it stay open? The ability to speak is an immediate indicator that the patient is capable of moving air. Stridor may be present on inhalation and exhalation, or both, and is an ominous sign. Same thing with kids. If a kid is screaming, crying, hey, that's great. That baby has an open airway. Breathing sounds from the nose and mouth should be free of sounds associated with any kind of obstruction. Those gurgling, gasping, crowing, wheezing, snoring sounds. Some patients use their body position to keep the airway open. We just want to assess the airway in the primary assessment and stop and fix problems immediately. Again, airway, breathing, circulation, those are our top 3 priorities. And if our patient doesn't have one of those 3 things, then we have to stop and fix those immediately. So airway assessment is not just a moment in time, but a constant consideration. It's true, especially for critical care patients. You always have to keep an eye on that airway. I've had patients that start off great, have an open airway, and then immediately crash and their airway is no longer there. So you may need to consider how to keep an airway open immediately after establishing it. When the airway is partially obstructed, you must consider how long it will be completely obstructed, until it will be completely obstructed. The ability to maintain an airway can change over time. Mental status affects the ability to maintain an airway. If they're altered, they may just be getting to be altered and they can maintain their own airway. But long term, there's no guarantee that it's going to remain open. So when we look at how to determine whether or not we have an airway, we look at what the signs of an adequate airway are. So no signs of breathing or air movement, evidence of any kind of foreign body in the airway, no air is felt or heard at the nose or mouth, they have the inability to speak or difficulty speaking, unusual hoarse or raspy quality to the voice, and also absent minimal or uneven chest rise. They'll have the breathing limited to the abdomen, diminished or absent breath sounds, abnormal noises such as wheezing, crowing, stridor, snoring, gurgling, or gasping. In children, retractions above the clavicles and between the and below the ribs. And also in children, nasal flaring. So we've determined that our patient doesn't have a good open airway. So how do we fix that? It has to be dealt with immediately. We want to open and maintain the airway in any patient who cannot do for themselves. In a patient with diminished mental status, airway procedures are best done with the patient supine. If you suspect spinal trauma, protect the head and neck. Airway has priority over spinal protection. Provide manual stabilization if time allows for it. In unconscious patients, watch for indications of head, neck, and spinal injury, mechanism of injury. The injury is at or above the level of the shoulders. Family or bystanders indicate such injuries occurred. Some patients may have an open but threatened airway. Conscious patients should be helped into a comfortable position, and unconscious patients should be placed in a head elevated sniffing position. This head elevated sniffing position is basically where we're going to kind of prop their head up at an angle and place their nose up in the air like they're sniffing. The slight elevation and interior positioning of the head allows the airway structures for improved patency. The head is moved in an anterior fashion similar to the posture used to sniff flowers. In supine patients, this may be achieved with a 1.5 to 2 inches of padding behind the head. Anatomy and head size can create unique positioning needs. And in pediatric patients, remember they have that big, huge occiput. And so it probably is best to pad behind the shoulders. Optimum positioning is when is achieved when the patient's ear is at the same level as the suprasternal notch. This position may be contraindicated when there is risk for spinal injury. Patients without an intact airway require manual airway opening and ongoing interventions to support patency. Airway problems are often caused by diminished control of muscles in the airway. Basic procedures keep the tongue in position and prevent the epiglottis from covering the glottic opening. The head tilt chin lift maneuver and the jaw thrust maneuver are commonly used. The head tilt chin lift aligns the airway structures to provide for free passage of air. You're going to place one hand on the forehead, and then your fingertips of the other hand on the center of the lower jaw. Tilt the head by applying pressure to the forehead, lift the chin, and support the lower jaw. Move the jaw forward and do not allow the mouth to close. Just like this. The jaw thrust maneuver is used to open the airway of the unconscious patient with the spinal injury. So basically what you're going to do is you're going to kneel behind the patient and then take your fingers on each side and thumbs on the cheekbones there. And you're going to just kind of push with your fingers upwards to open that airway. Obstructed airways. So if an open airway remains obstructed, consider the possibility of a foreign body obstruction. If you attempt to ventilate and reopen and it still fails, immediately begin foreign body airway procedures. Choking is classified as either severe or non-severe. In severe choking, the trachea is fully blocked and no air is moving. In non-severe choking, the trachea is partially blocked and some air is exchanged. Conscious, severely choking adults are treated with abdominal thrust. We want to stand behind or kneel behind the patient. Place a fist over the navel and grasp the fist with the other hand. Press into the abdomen with a quick, forceful upward thrust and repeat the thrust until the obstruction clears. Conscious, severely choking infants are treated with back slaps and chest thrust. We want to deliver 5 forceful back slaps and 5 rapid chest thrusts. If you cannot wrap both arms around the adult patient to deliver those thrusts, position the hands over the sternum. If the choking patient is unconscious or becomes unconscious during airway maneuvers, begin CPR. Let's talk about airway adjuncts. Manual maneuvers open the airway, but an obstruction may resume when a maneuver is released. So we can do the head tilt chin lift, the jaw thrust, all those things to open the airway, but is it going to stay open if I let that go? So we need airway adjunct. It basically aids in maintaining an open airway. There are 2 types of common airway adjuncts, the OPA and the NPA, or the oropharyngeal airway and the nasopharyngeal airway. The main function of these devices is to keep the tongue from blocking the airway when muscle tone is diminished. Use an OPA only on patients not exhibiting a gag reflex. That gag reflex may reappear as a patient regains consciousness. Good way to tell if the patient is unconscious, you can tell if they have a gag reflex. Sometimes, it doesn't work all the time, but if you take your finger and just lightly rub over their eyelashes, then you can kind of tell if they have a gag reflex, if the eye moves. If an OPA is not tolerated, an NPA may be. Open the patient's airway manually before using an adjunct device, and when inserting the airway, take care not to push the patient's tongue into the pharynx. Always have suction ready prior to inserting the airway, because they may gag and vomit. Do not continue inserting if the patient begins to gag. Maintain head position after the adjunct insertion and monitor the airway. Continue to be ready to provide suction if fluid obstructs the airway, and if the patient regains consciousness or develops a gag reflex, remove it immediately. Always use infection control practices. So an OPA is a curved plastic device inserted into the mouth to keep the airway open. It has a flange that rests against the patient's lips, and it moves the tongue forward as it curves back to the pharynx. OPAs come in standard sizes, range in size from an infant to adult. A complete set should always be carried, and airway is not effective unless it is the correct size. Okay, so these are OPAs or oropharyngeal airways. They do come in various sizes. These grooves along here allow air to enter and for you to be able to get suction in. To determine the size, we want to measure the device from the corner of the mouth to the tip of the earlobe on the same side. Alternatively, you can measure from the center of the mouth to the angle of the lower jaw. Do not use the device unless you have measured and verified the size. And if the airway used is too big, air will be directed into the stomach instead of the lungs. Okay. So from the tip of the jaw to the earlobe, or I'm sorry, from the tip of the mouth to the earlobe. And that is from the middle of the mouth to the jaw, where it starts to circle and curve backwards. Place the patient on their back. Use appropriate manual method to open the airway. Open the mouth with a crossed finger technique. Position the device with the tip pointing toward the roof of the mouth and insert the device along the roof of the mouth. So the crossed finger technique, tip pointing upward. Gently rotate the airway 180 degrees so that the tip is pointing downward into the patient's pharynx. Position the patient. Check that the flange of the airway is against the patient's lips and monitor the patient closely. An NPA is used when there is no intact gag reflex, when there is an intact gag reflex, teeth are clenched, or there are oral injuries. It may be contraindicated with a basilar skull fracture, epistaxis, or nasal trauma. It's a soft, flexible airway that should be used in the field rather than rigid, clear plastic airways. So you want to measure for correct size from nostril to the tip of the earlobe to the or the angle of the jaw. Lubricate the outside of the tube with a water-based lubricant before insertion. Push the tip of the nose upward and insert the airway. Keep the head in a neutral position. Point the bevel toward the base of the nostril or toward the septum. So you're going to measure from the tip of the nose to the tip of the ear. Lube it up. Push the nose forward or upward. And then insert. Advance along the floor of the nasal pharynx. The flange should rest firmly against the nostril. Supraglottic airways. So in Missouri, you guys can place a supraglottic airway. These isolate the glottic opening by occupying space in the larynx and hypopharynx. Airways are indicated when other basic measures have failed. May also be used if the airway must be maintained over a long period. Specific insertion steps vary by airway manufacturer. So general steps for inserting a supraglottic airway. Prepare the patient. Attempt simple procedures first. If these fail, position the patient's head. Pre-oxygenate the patient. Prepare the team. Discuss roles and responsibility. Assign suction, assessment, and equipment duties. So you're going to prepare the device. Size the device per the manufacturer's instructions. Attach and check any required inflation devices, and prepare suction. Suctioning. So you can use gravity to clear an airway. These foreign materials that remain in the airway may be forced into the trachea and lungs, causing complications. Gravity can be used to clear fluids from the mouth by turning the patient on to one or the other side, it doesn't matter, and allowing the fluids to drain. This is fast compared to technical alternatives. It can be done while devices are being prepared. It cannot be done with spinal injuries or when there's a single responder. And when using gravity, always turn the patient away from your body, obviously, because you don't want to get any of that stuff on you. Suctioning devices. So suctioning uses a vacuum device to remove foreign materials from the airway. A patient with fluid or secretions present or gurgling sound should be suctioned immediately. Each suction unit includes a suction source, collection container, tubing, and suction tips or catheters. There are vehicle-mounted or onboard suction units. These create a suction vacuum using the engine's manifold or an electrical power source. You must furnish an air intake of at least 30 liters per minute at the end of the collection tube, and it must generate a vacuum of no less than 300 millimeters of mercury when the collection tube is clamped. Portable suction units may be oxygen or air powered, electrically powered, or manual. Must provide an amount of suction identical to that of an onboard unit. So operation of a suction unit requires tubing, suction tips, suction catheters, collection container, and a container of clean, sterile water as well. Most popular tip is a rigid pharyngeal tip, also called a Yonker or a tonsil tip. It allows the mouth and the pharyngeal suction with excellent device control. It has a larger bore than more flexible catheters, and it is most successful with unresponsive patients. Suction catheters are flexible plastic tubes, come in different sizes, and are identified by a number French. It is designed for use in situations when a rigid tip cannot be placed. Collection containers should be non-breakable and easily removable, and the water container is used to clear partially blocked tubing. Infants and pediatric suctioning. So infants are very sensitive to that vagal stimulation that occurs when we place the catheter onto the hypopharynx. They respond with a slowing of heart rate. We want to minimize the necessary suction time and take care to avoid hypopharyngeal contact. Bulb syringe suctioning is common for infants and small children. It's very effective in clearing small airways. It is used in birth and when infants experience respiratory distress. So techniques for suctioning: always use appropriate infection control practices. Limit your suctioning to no more than 10 seconds at a time. Place the tip or catheter where you want to begin suctioning and suction on the way out. Suction is best delivered when the patient is on their side, and suction devices may activate the gag reflex or stimulates vomiting. So, definitive care to keeping an airway open. So keeping the airway open may exceed the capabilities of a basic EMT. We want to rapidly evaluate and treat airway problems, quickly recognize more definitive care is needed, and we may have to have ALS intercept. Special considerations: so facial injuries, bleeding may require frequent suctioning. An adjunct or endotracheal tube may be needed. Obstructions, suction units are not adequate for removing solid objects. You want to use abdominal thrust and chest thrust or finger sweeps. Again, we're not going to do any kind of blind finger sweep. If we can see it, we can do a sweep. Otherwise, we're not going to do a blind finger sweep. Dental appliances, these should be left in place during airway procedures. Partial dentures may become dislodged during an emergency, and just be prepared to remove a device if it endangers the airway.